moved on to our next speaker, Dr. Anton HOMMER from Austria, and he'll be speaking on what we have learned from trials on normal tension glaucoma.
So good morning, ladies and gentlemen. I want to thank very much for inviting me here to give the talk. It is a great pleasure for me to be in this very interesting and fascinating country. For those of you who had not made any sightseeing, this is from the biggest mosque in India, and it's really very nice to see that. So my topic is about the trials in normal tension glaucoma. My financial disclosure is none, but the first thing is actually we have to be sure that it is normal tension glaucoma. I don't know how it's in India or in Asia. I can tell you in our country, for example, the misdiagnosis is very frequent. Gonioscopy is not performed frequently, and you can see it here in the United States, Canada, and South Korea. They didn't make sufficient evaluation of the angle, so how can you be sure that it's not maybe angle closure or something like that? The same is with the intraocular pressure measurement. We know that the intraocular pressure can fluctuate quite a lot in the normal 6 millimeters, and in the sick disease one, you have a fluctuation of 10, 15 or more, and maybe these IOP levels are not during your office hours, but in the night. Pachymetry, we know that there is no calculation of formula that you should need, but corneal thickness for sure is a relevant topic to consider. And then the position, of course, as well. When you measure the intraocular pressure, you should think about how is the condition and how is the pressure in the different positions. And then, of course, there are other optic neuropathies we have to consider, that they are maybe at the first aspect leading to the diagnosis of glaucoma, but there is another reason behind it. And of course, the visual field, which is a psychophysiological examination, depending very much on the mood of the patient. Is it really reliable? And the defect is only reliable if you have it confirmed at 2 consecutive visits. So we should make more visual fields as well to be sure. And then, of course, there can be other reasons why the pressure has been elevated in the past and produced the damage, but now maybe it's not anymore, like pigment dispersion, where you had steroid therapy, trauma, or other reasons. So is a normal tension glaucoma arbitrary? So I have to go, being European, to the EGS guidelines, the European Glaucoma Society, yes? And there it is clearly said that a substantial proportion of patients develop primary open-angle glaucoma at IOPs within the normal range. Primary open-angle glaucoma has been arbitrarily subdivided into high-pressure and normal pressure diseases. So glaucoma with low intraocular pressure levels may be more common in women with vascular dysregulation, migraine, and Raynaud, and we can have disc hemorrhages and paracentral scotomas. They are more common probably in the normal tension glaucoma. We have 2 main studies that deal with this topic, and it's the collaborative normal tension glaucoma study, which is now 27 years ago, and the early manifest glaucoma trial. And you are familiar with the first one, where they were looking on patients where they made intervention with treatment of medication, laser, or surgery, and the other group had no treatment at all. And the outcome was the progression of the disease. And there you could see then nicely that there were 230 patients eligible, but only those who exhibited a real confirmation of the visual field defect were randomized, and these were 140, so nearly 100 less. And a 30% intraocular pressure reduction from baseline was the treatment goal and was maintained in nearly 50% of the patients. But progression occurred despite of that in 12% of the treated patients and 35% of the controls, so 3 times more of the controls. But of course, there is a significant part that did not progress. So 65% of untreated pressure patients had no progression over the years. So, but the beneficial effect of intraocular pressure lowering was found only after the data was censored for the effect of cataract formation on the visual field, because they found out that cataract formation has a significant impact on it. Yeah? And cataract surgery, cataract was more common in patients treated with surgery. And we know that surgery, glaucoma surgery, induces and stimulates cataract formation. And the EMGD study, the early manifest glaucoma trial, which was done in Sweden, yes, was treatment versus no treatment. And it's interesting, the primary outcome measurement was progression of the disease. Yeah? And it's an old study, it was from 1993 to 1997. And they had to have a substantial visual field deterioration or optic disc change. And when we look then, 25% decrease from baseline, and the mean IOP at baseline was 20.6. So there have been quite a number of normal tension glaucoma patients included in this study. Yeah? But it was a reduction of the relative risk of progression of 50% over the time. And the important risk factors in this study were pseudoexfoliation, higher intraocular pressure, more baseline damage, higher age, disc hemorrhage, thinner cornea, and low blood pressure in the normal tension glaucoma patients. And this is an interesting link, and we know that there is some relation for the general conditions to it. Untreated progression was slower in the normal tension glaucoma than in the high tension glaucoma eyes. And pseudoexfoliation, of course, has a very negative influence, and these eyes progressed much faster. The frequency of disc hemorrhages was higher with low intraocular pressure in women, especially, and with myopia, and it was not influenced by any treatment. And then there is this recent study from China, and where they were looking in Wenzhou about normal tension patients. It was a prospective untreated study of more than 2 years. Actually, the average observation was 70 months. Yeah? And the functional progression was defined as a visual field deterioration or structural change in this. And the conclusion was that nearly 2/3 of the untreated Chinese patients with normal tension glaucoma progressed over an average of 70 months. Disc hemorrhage, female gender, again, high pressure, shorter axial length, and lower blood pressure were significant predictors for the disease. So here you can see nicely, it is interesting that about 2/3 of the patients were female in this study, and the baseline IOP, it's just 1 millimeter of mercury, but statistically interesting, yes, and the history of disc hemorrhage is significant as well. And then when you look into this study after 2 years, and you look just on visual field progression, you do not see too much progression. The same is with the structural progression, it's not too much after 2 years. But if you look at the glaucoma progression and combine, then you see after 2 years yet a significant change. The limitation of this study is that it's a small sample size, only 84 eyes, and it's a mild stage of glaucoma, and they were not looking on family history, migraine, and others. Being in India, of course, you should mention a little bit about yoga. There is the recent study, effect of yoga on pressure, and there is this review, and they were looking controversial results. And you have, in these 3 studies, you see the lower 2 ones, they had an intraocular pressure far below 20, so there were quite a number of normal tension glaucoma patients seen in here. And in the discussion, then they say that the reduction of intraocular pressure following some specific positions of yoga, I'm not doing yoga, so I can't tell you anything personally, means that you can have a lowering of intraocular pressure, but there is an error as well. You can have a rapid increase after the beginning of the pressure. As a summary, they say that practicing yoga positions where you postpone your head down, these are the ones, you should not recommend for your glaucoma patients. So what is the difference at the end from high pressure glaucoma to normal tension? The pressure level, of course, the visual field defects, they are looking different. The optic nerve head can look a little bit different. You have the images, and you have the risk factors from a general aspect. But similar is the target. The target is the intraocular pressure, and we know that we need the lower intraocular pressure. We know that ocular blood flow could be, to a certain extent, different in normal tension glaucoma compared to primary open-angle glaucoma, and the systemic conditions play a role. So what are the needs in normal tension glaucoma? It's very low target pressure. It's like in an advanced open-angle glaucoma. We should reduce them significantly. But there is not so much evidence about making more trabeculectomy, therapy of the blood flow, neuroprotection, citocolin, nicotinamide, or other things. So as a summary, normal tension glaucoma is to some extent different to high pressure glaucoma, but lowering the intraocular pressure is the only evidence-based approach we have. The lower the better, but we know that some progress anyway, especially in these patients. I would use other options as well, especially if the patients are asking for that. With this, I want to come to the end from Gandhi, who said, do not listen to rumor, but if you do not believe it. I hope this doesn't fit to my presentation, and I thank you very much.